Hi everyone, I'm Anu Kathiresan, fertility physician and Dr. Mom, and here to educate on fertility. In this video, we'll be talking about how to prepare for an egg retrieval, what to do to prepare for an egg retrieval, what to expect the day of, what to expect the next day, what is the recovery like, what are the next steps. So let's start talking about some of these things today. Preparing for the egg retrieval. The first thing is that IVF involves taking injections for a period of 8 to 10 days, usually leading up to the egg retrieval. And as much as possible, which I know it can be hard, but as much as possible, it's good to have a flexible mentality when it comes to timeline, because we truly won't know which day the egg retrieval is going to fall at the beginning of the process. The closer we get to the time of the egg retrieval, the more we'll be able to estimate what day the egg retrieval will fall, but we really won't know until 48 hours prior to the egg retrieval. The other thing to plan for is on the day of the egg retrieval, we want you to take it easy. So don't plan any appointments. Don't plan to catch up on that work project you've been meaning to catch up on. We want you to take it easy because you're in that 24-hour recovery period. So maybe catching up on that book you've been wanting to catch up on, or the Netflix or Hulu series you've been wanting to catch up on. These are the type of things I would plan for. Also, on the day of the egg retrieval, you will have anesthesia, so you'll need somebody to drive you home that day and to be with you for the first 24 hours after the procedure to check on you and also just to be there if you need anything. The last thing is going to be the timing of the trigger and the timing of the egg retrieval. So these things are very important. The purpose of the trigger is to trigger the last steps of egg maturation and also to help the egg release from the follicle wall so that we'll be able to retrieve it. It will also time ovulation. We plan to do the egg retrieval just prior to ovulation. We don't want you to ovulate prior to the egg retrieval because you will release the eggs with ovulation and then we will not be able to retrieve them. So the timing of everything is very important. So when it comes to trigger time, I would set up maybe 30 minutes in advance. Make sure you have all your syringes, needles, everything's ready to go so that you do the trigger at the exact right time that you need to do it. Then the egg retrieval. So the egg retrieval is going to be timed about 35 to 36 hours after the trigger. Now, the time that you arrive is going to be important. We want you to arrive usually 45 minutes in advance. There's some setup we need to do. We need to gown up, go over some instructions, put in an IV, talk to the anesthesiologist. So it's important to make sure you're not arriving at the procedure time, but you're arriving at the arrival time. There's going to be a difference there because we have to do that prep work. The other thing that's good to remember is planning in advance if there's traffic or if you live on the other side of town, maybe planning to stay at a nearby hotel, but making sure that you arrive on time so that the procedure falls on time because we don't want you to ovulate and we don't want to lose any of those eggs. On the day of the egg retrieval, we want to make sure you didn't eat anything after midnight the night before the procedure. We want you to be as relaxed, as positive as possible, not stressed, rushing to get there. So try and plan in advance for that. It's good to wear comfortable clothing, comfortable pants, shirts, things that are easy to get in and get out of before and after the procedure. And also we want to make sure you're not wearing any fragrances, perfumes, deodorants, just anything that could potentially have an impact on the eggs. Once you arrive that day, you'll meet with the nurses. They'll go over a few more instructions, and then they'll go ahead and put in your IV. Then you'll go ahead and gown up. So basically you're going to completely undress. We'll give you a gown. We'll put your hair up in a bouffant. So your hair is under a cap, and then you can bring your own socks or we'll provide socks. And then we also provide these little booties that you'll put on over the socks. And that's essentially how you get ready for the OR. Then you'll meet with some of the people that are going to be in the room with us. So the CRNA or anesthesiologist will meet with you, answer any questions pertaining to the anesthesia. And then you'll meet with the physician also, answer any questions that you may have for the physician as well. Now, as a physician, we always review the flow sheet prior to the procedure and know how many follicles are there and size. So we have in our mind an estimation already of how many eggs we're aiming to get. Now, I always go over with the patients that it's not always that the egg will release from the follicle wall, not always the follicle's normal and has an egg in it. But having said that, I'm going to do my very best to get as many eggs as I possibly can. So sometimes we get lower than we expect for some of those reasons I mentioned. Sometimes we'll get a little bit more than we expect. So that could be maybe there were a few extra follicles there, or there were a few smaller follicles there. So we always try and get as many eggs as we can, even if they're from the small follicles. The only issue with the smaller follicles is that the smaller the follicle, the more likely it is to have an immature egg in it. And we need a mature egg in order to put an egg and sperm together. But we're always going to try and get as many as we can. And so that's sometimes why we get more than we anticipate. Then it's time to move into the operating room. So we'll have you empty your bladder, and then we'll walk you back to the operating room, and then you'll lay down on the bed, and we'll put some monitors on you so that the anesthesiologist can monitor your vital signs during the procedure, and then they'll put you to sleep. You are not intubated where you have a tube down your throat for the procedure, but you are in a nice deep sleep so that you won't feel anything during the procedure. The procedure length can vary. On average, it's about 15 to 20 minutes, but the length really depends on how many eggs are there. Prior to the patient undergoing anesthesia, the embryologist will actually come into the room and introduce themselves to the patient, and they'll verify their ID badge, verify their name and date of birth, and all of the setup that the embryologists have the patient's name and medical record number. So there are many steps of verification through this process. Once the patient then undergoes the anesthesia and are in that deep sleep, we will start the procedure. The procedure starts with a lavage or cleansing of the vagina. So what we'll do is we'll put a speculum in, and we'll just flush the vagina with saline or water. That is our way of cleansing the vagina before we start the procedure. We don't want to use betadine. Betadine can be harmful to the egg, so that's why we perform this cleansing. Then we set up a few things. We set up the ultrasound probe with a sterile probe cover, set up some of the tubing, and set up the needle. And then we're ready to proceed. We do place a needle guide on top of the ultrasound probe. It kind of clicks in, and there's a little hole through the needle guide. So this is where we'll introduce the needle through. The needle will just rest above the probe until once the ultrasound probe is in the vagina. So when the ultrasound probe is in the vagina and we advance the needle is just resting above the probe until we get to the back of the vaginal wall, and then it will go through the wall and into the ovary. Once it's in the ovary, we always align the ultrasound probe with the follicle we're aiming to go into. So once we're in that follicle, we'll step on a pedal. This will activate a vacuum suction. So we're essentially vacuum suctioning the fluid out of each follicle. Each follicle, in theory, has a microscopic egg that we can't see. So as we're removing the fluid, the egg should come with it. It'll travel through the tubing into the test tube, and then we hand the test tube off to the embryologist. They'll be looking through the fluid under a microscope, and they will identify the eggs, and they will give us a running count of how many eggs that they're able to identify during the procedure. We try and use one puncture site for each ovary. So once that first follicle is collapsed, we'll move on to the next follicle until we've gone through all of the follicles in that ovary and removed as many eggs as we can from that side, from that ovary. Then we will flush out the needle and move on to the other ovary, and then do the same thing where we go through as many follicles as we can to remove as many eggs as we can. After that, the procedure is pretty much complete, but we do want to make sure there's no bleeding. So we'll put a speculum back in, look at those puncture sites, and make sure that they are hemostatic, meaning not bleeding. And if they are, sometimes we'll use a little medication at the site, or rarely put it in a stitch, but usually the bleeding is minimal. That takes me to risk of an egg retrieval. So an egg retrieval is a minor surgical procedure, but surgical procedures can still have risks. So the risks are bleeding, infection, damage to nearby organs. So that includes the bladder above and then the bowel. Now, we are keeping an eye on the needle throughout the procedure, and we always perform the procedure as safely as possible, meaning if there is bowel in our way of getting to the ovary, then sometimes we're not able to proceed because we don't want to injure the bowel or bladder. We always want to perform the procedure as safely as possible. So the chance of risk to any of these structures are very low because of that. Immediately after the retrieval, it can be like waking up from a nice nap. You'll be able to drink a little bit, you can eat a little bit if you'd like, and you can use the restroom if you'd like. They'll assist you with that. The recovery from the anesthesia, so it usually takes about 10 minutes to wake up from the sedation, and then we'll usually recover you for an additional 30 minutes. So the total amount of time that you're at the facility for the procedure is usually around 2 hours. Then once you're ready to go home and you'll need a ride to take you home, you'll know the number of eggs that were retrieved before you leave that day. After that, the embryologist will keep you updated in terms of the number of eggs that were mature, how many fertilized, and how the embryos are growing in the subsequent days. It's going to be normal after the procedure to have some light bleeding and also some cramping, so I would expect these type of things after the procedure. The recovery time for a retrieval is usually 24 hours. However, there are certain patients that are at increased risk for what's called ovarian hyperstimulation syndrome, or OHSS. Patients that are going to be at higher risk for this are going to be young patients with a low BMI, a high AMH, a high follicle count, and when they're going through the IVF process, a high follicle number and a high estrogen level. Things to be on the lookout for if you are a patient at risk for OHSS are going to be worsening abdominal pain, worsening abdominal bloating, nausea, vomiting, chest pain, shortness of breath, decreased urine output, and increasing weight gain. So it's important to keep your clinic updated if you are experiencing these symptoms. Interestingly, it can flare up more after the retrieval, and it can flare up even up to 7 to 10 days after the egg retrieval. So it's important to keep an eye out for these things if you are at risk for them, and to keep your clinic updated, because moderate to severe symptoms are going to require further treatment. Other things that you can always do are going to be to drink lots of fluids, drink Gatorade, and also a high protein diet. These things will help to alleviate some of those symptoms. After an egg retrieval, the embryologist will keep the patients updated on how the embryos are progressing. So on the day of the egg retrieval, you'll know how many eggs we got. On the next day, which we call day 1, you'll know how many eggs were mature and how many of those mature eggs fertilized. On day 2, the embryologist will let the patients know how the cells are dividing in the embryo, and same thing on day 3. We usually don't check the embryo on day 4, and then on day 5 or day 6, we'll know how many blastocysts that we have. Now, after the embryo gets to the blastocyst point, the next steps depend on what the patient and the physician have decided. So sometimes that will be a fresh embryo transfer where we go ahead and put the embryo back in. Sometimes it'll be a frozen embryo transfer and we'll just freeze the embryo. Sometimes it will be biopsying the embryo for pre-implantation genetic testing to know the genetics of that embryo, and then freezing the embryo. So the next steps really depend on what the patient and the physician have already decided in advance. If the patient is doing a fresh embryo transfer, the patient will start medications after the egg retrieval for preparation for that transfer. If the patient is freezing embryos, then the patient will just basically wait for their next period, and that can take usually up to 1 to 2 weeks after. Now, if the patient did genetic testing, those results usually take about 2 weeks or so to get the results. So we'll set up a follow-up visit with the patients, usually about 3 weeks after the egg retrieval, in anticipation that we'll have the results at that time, and then we can review the results with the patient at that visit and then figure out our next steps from there. If patients are undergoing egg freezing, then we'll know how many eggs the patient got on the day of the egg retrieval, and we'll know also how many mature eggs on the same day. So we just set up a follow-up visit 1 to 2 weeks after the egg retrieval with the patient, and at that visit we'll review the number of mature eggs we got, and we'll correlate that to probability of live birth. There are research studies that have looked at this, and so we'll look at the patient's age, the number of mature eggs that they got, and how it correlates to probability of live birth. It's important to keep in mind that, yes, we'll know how many mature eggs the patient has, but we won't know the quality of those eggs. So it's possible that not all of the mature eggs that we got are good quality. And so these probability tables help to understand what this really correlates to in terms of percentages of live birth, and then we'll review if the patient is happy with that percentage, or if they're not, we'll review the cycle and we'll see what information we gathered from that IVF cycle, and if the patients want to try the process again to increase the number of eggs that they have so that they can increase that probability of live birth for the future. In the end, I want patients to be as well informed as possible on best case scenarios, but also worst case scenarios. And after being aware of this, just moving forward as optimistic as we can, knowing that we're going to do our very best to get you as many embryos as we possibly can. That is it for this video. I hope you found it helpful. If you did, I hope you'll give the video a like. Don't forget to subscribe down below. If you have comments or questions, you can leave them for me there also. Thank you again so much for watching, and see you in the next video.